To invite you to a special vascular meeting. This meeting is designed to collect all what is new in the vascular environment in the last 5 years. We will gather what is new, which technique, which devices, and which diseases that we started to treat them differently. This is collaboration between two big societies, the Egyptian Vascular Club and the Vascular Society of Egypt, VOT. We will be in May in one of the most beautiful cities of Egypt, in Alexandria, on the 15th and 16th of May 2025. We hope to see you all there. I'm sure you will get a lot of memories, a lot of friendship, and a lot of benefit and information as well. I wish you all the best. My name is Dr. Muhammad Amr Farouk. I'm a consultant vascular surgeon. Bismillah ar-Rahman ar-Rahim, my dear vascular colleague. I would like to invite you to a special vascular meeting. This meeting is designed to collect all what is new in the vascular environment in the last 5 years. We will gather what is new, which technique, which devices, and which diseases that we started to treat them differently. This is collaboration between two big societies, the Egyptian Vascular Club and the Vascular Society of Egypt, VOT. We will be in May in one of the most beautiful cities of Egypt, in Alexandria, on the 15th and 16th of May 2025. We hope to see you all there. I'm sure you will get a lot of memories, a lot of friendship, and a lot of benefit and information as well. I wish you all the best. My name is Dr. Muhammad Amr Farouk. I'm a consultant vascular surgeon.
I think now we are online. Bismillah ar-Rahman ar-Rahim. My dear professors and my dear colleagues, today we will start our second journal club of the Egyptian Vascular Club with my great honor to for the attendance of the discussion board, Professor Adel Al-Kamhawi, Professor of Vascular Surgery in Tanta University, and my dearest professor, Professor Omar Al-Farouk, our greatest consultant of vascular surgery in the general organization of teaching hospital and institute, and also my great pleasure to know that Professor Walid Khreiba is give us the honor to attend the meeting now. Our discussion today about a paper, its title about the clinical outcome for the different modalities of management of varicose vein, including the radiofrequency, the cyanoacrylate, and non-thermal, non-tumescent technique, and also the surgical stripping. And our presenters today, Dr. Muhammad Talat, the Senior Resident of Vascular Surgery in the National Institute of Diabetes, and Dr. Muhammad Radi, the Senior Resident of Vascular Surgery in National Institute of Diabetes. And kindly, I will leave the talk for them to present the paper at first, then we will go for the discussion and criticism. Dr. Talat, please.
Thank you, Dr. Mustafa. Dr. Muhammad Radi will first present our paper.
Okay.
Then we're gonna discuss the paper together.
Okay, Dr. Radi, please. Dr. Radi, kindly, you are muted.
Good evening, my dear professors. I'm glad to join the second online journal club meeting for January 2025 meeting. Today we will be discussing the clinical outcomes of non-thermal ablation, thermal ablation, and surgical stripping for varicose veins The paper published in November 2024 in the Journal of Vascular Surgery, conducted by Kim et al. Of the University Hospital of Ganghee, Seoul, in collaboration with the Medical Center of Stony Brook University in New York. Well, varicose veins are superficial, dilated, and tortuous veins usually caused by superficial venous reflux. It's an extremely common disease. Up to 20% of adult males and 2/3 of adult females have varicose veins. The management of venous diseases is a major cause of health expense worldwide. Yet venous vein surgeries are one of the most performed surgeries. We've got various treatment options available for incompetent saphenous veins. We've got the surgical approach which has been always known as the surgical stripping, and we've got the endovascular approach through thermal ablation, known as the radiofrequency ablation, either or endovascular laser ablation. We've got also non-thermal ablation, known as cryoacrylate closure or mechano-occlusive chemical ablation. Each has its, their efficacy have been known to be similar, proven in by other papers which have been published and have been referred to in our paper. However, the benefits and drawbacks of each treatment modality has to be considered, as it has its own, as we have to choose the best treatment modalities according to our patient's needs. The aim of this study is to compare the clinical outcomes of radiofrequency ablation, cyanoacrylate closure, and mechano-occlusive chemical ablation and surgical stripping for incompetent saphenous vein, and to identify the most suitable treatment modality for specific clinical situations, and also to define the selection hierarchy of each treatment modality based on factors such as proximity of the nerves or skin, proximity of the vein to the nerve or the skin. The methodology of this study. This study was conducted as a retrospective single-centered observational study. It included about 866 patients with primary varicose veins. It included patients who conducted intervention in the period between July 2012 till January 2023. The inclusion criteria of this study, it included symptomatic primary varicose veins patients of C2 till C6 clinical grade according to the C classification. They excluded all the patients with congenital vascular malformations, non-saphenous varicosities, and current ongoing DVT, or also patients with post-thrombotic syndrome. The primary outcome of this study was the incidence of post-operative adverse events, and also the incidence of recanalization. Recanalization was defined as the reopening of an area that was previously closed, or when the saphenous trunk length increases than the immediate post-operative length. The secondary outcomes for this study was the quality of life according to the patient as per the Aberdeen Varicose Veins Questionnaire, and also the procedure time, access site of truncal ablation, and the stump length immediately post-operative and after 6 months. This was the baseline characteristics of the patients included in the study. As we can see, most of the patients have underwent radiofrequency ablation, and most of the patients who have underwent mechanochemical ablation were of the younger age, given that the mean age of those patients was 44 years old. Female sex is the most, most of the patients are from female sex, and most of the patients who have underwent surgical stripping were of male sex. Here in this table, it elaborates the post-operative complications which has happened during this study. The DVT was noted in the the group of the cyanoacrylate closure. And as for also for the hypersensitivity, it occurred also mostly in the patients who have underwent cyanoacrylate closure. The conclusion of this study, that the authors concluded that the clinical outcome with improvement of quality of life were comparable among the different treatment modalities, and the proximity of the nerve or skin to the target vein is the most important factor in selecting a suitable treatment modality. And they elaborated further through this illustration, given that patients who have junctional aneurysm or superficial located truncal vein of less than 5 millimeters depth are more prone to have stripping than to undergo other treatment modalities. And if is there a risk of nerve injury, it would be better to do a non-thermal approach. And if general anesthesia is preferred, or the patient has a moderate to severe varicosities, it is preferred to approach them through the radiofrequency ablation technique. Now I handle the discussion to my colleague, Dr. Mohammed Talat.
Thank you, Dr. Radi.
Before you are talking, Dr. Talat, let me introduce my professor, Dr. Khalid Abdelal. He just joining us in this meeting. Our privileged sir to join us.
Thank you. I'm very sorry for being late, my friends, but I keep searching for the link I couldn't find. So I'm very, very sorry.
Thank you all. First of all, I want to thank you all our dear professors for us to give us this great opportunity to have this live discussion with you, and I hope we got the most benefits from it. So as my colleague Dr. Radi reviewed our paper and its aim and conclusion, we now gonna discuss and analyze it in a little bit detailed way. First of all, we're gonna talk about the study design that's used in this paper, which was a retrospective cross-sectional observational single-centered study. We see it's not an appropriate design for that kind of study, and we see it will be more preferable and reliable if we use a randomized controlled trial study for this kind of study. Also, as we see in this slide, there are more than one paper that addressed that has the same address topic that has been published in 216, 218, and 2021. So our study here has no original idea in it. Also, although our author mentioned the inclusions and exclusions criteria in his study, but he didn't clarify or explain why did he exclude the secondary varicose veins, patients with secondary varicose veins or post-thrombotic varicose vein from this study, as it has a strong relation to our study here, and we have to know the effect of different modalities in these patients also. We see that this study is not adequately controlled, as it is not randomized and it has a systemic bias. This bias can be explained through many points. First, the difference cost between the different modalities of treatment for the varicose veins may affect the determination of the modality of the treatment. Many patients may prefer cheaper modality than more expensive one. Also, the preference of the surgeon himself to do a specific or a certain modality of treatment This all may affect our results and our outcomes from the study. Also something that has been mentioned already in the study, that the long duration interval of the study put the author in the issue of the availability of different modality of treatment during the different period of the study. The study took almost 10 years duration, which means the early period of the study didn't include the recent interventions or modalities of treatment that has been used recently. Finally, our study here lacks a clinical scoring system which provides us with a more dynamic assessment for the severity of the disease over time, and in response to the treatment. Here in the study, it also depends on the Aberdeen questionnaire, which is not that reliable for assessment of and evaluation of our interventions and follow-up with the patient. That's all our weakness point, our weakness points that we have noticed in the study, and we hope if you have any other weaknesses or something we're gonna discuss together, it's all yours. Thank you so much.
Thank you, Professor Talat. Dr. Talat, our dear professors.
حاجة ممتازة. أبدأ؟
اتفضل يا فندم طبعا.
Should I start?
Yes.
Thank you.
Yes,
Thank you very much for the touch of this critical point. I agree with some points. First, this cohort is not homogeneous, it is heterogeneous from the point of age. With the advance of the age, we have more incidence of varicose vein. So we had to select patients of a limited age, between 18 and 45 or 60. Because, for example, pediatric age group with primary varicose vein is not common in Europe or Korea, but we have here social indication. You know, the admission to military faculties or before the age of marriage, which is in Egypt 18 years, and every female seeks to be 100% healthy before marriage. So we have what is called social indication. But all guidelines put the indication for varicose vein when it is only symptomatic, not cosmetic. So cosmetic only is not indication, but with complication starting from pain, then superficial thrombophlebitis or a hemorrhage. This one point. The other point, heterogeneity of stage of varicose vein. I cannot put from the stage 2 to stage 6. Stage 6 is ulceration and lipodermatosclerosis, stage 4 and edema. So I would prefer only stage 2 with truncal reflux, because the definition of stage 2 is a vein with diameter 3 millimeter with or without truncal reflux. So it were subjunctive mode to be diameter more than 3 millimeter and with truncal reflux. But I couldn't put varicosities of tributaries as varicosities of truncal saphenous vein. So you are right, it is heterogeneous. For the indication of surgery in the paper, this was very good to mention that superficial truncal vein. But the tortuosity of the vein, severe tortuosity of the vein, is another indication of surgery. You cannot go with the wire or catheter and thermal or non-thermal in superficial tortuous vein, truncal. So you are right. Other points for the indication of surgery, previous indication or incidence of superficial thrombophlebitis, which is a complication in varicose vein. You cannot go through the vein. You need surgery. So you are right. We need to put homogeneous population, homogeneous disease, and the point of recurrence. It is not a recurrence. Is it a recurrence of varicose vein or recurrence of the disease? The disease is already there. You had treated the varicose veins here, but the body has genes or has a liability to form new varicose veins. So I cannot say this is a rate of recurrence because I ablated thermal, non-thermal, or surgical, but the patient had the ability to form new varicose vein over the time. So you are right. Over the 5 years, we don't have the rate of recurrence. You had shown us the papers. The best of them, it was for Rasmussen, 2013, I think so. Comparison of all modalities, and the conclusion was all are equal in the rate of recurrence, about 30% over 5 years. But I don't think it is a recurrence. It is a formation of new varicose vein because the disease is already there and the patient has the ability, and we cannot stop the process of formation of varicose vein till now. Thank you very much.
Thank you, sir. Dr. Khalid.
Yes, very much. Thank you very much for these efforts. Well, I don't disagree for some weak points that you mentioned, Dr. Talat. You said that it is a 10 years study and it did not include recent technique. What else recent technique do you know? According to my knowledge, these are all the techniques available now. So what are you missing as recent technique?
I mean, Dr. Khalid, that the recent modalities were not applied in the early period of the study. That's what I mean. That affect the number of the cases.
Of course. So in that condition, yes, you are right. There is a complete bias because the numbers are not equal.
Yes.
Not because they did not include. But if you see 10 years ago, for example, MOCA was not very common and radio frequency even was not very famous. So the bias I see is the numbers are not equal. You are comparing more than 1,900 radio frequency with small amounts of MOCA and cyanoacrylate injection.
Surgical stripping also.
Yeah. Second thing, what I really missed in this paper, that I don't know if you noticed, the rate of deep venous thrombosis and the rate of pain. Even the case of open surgery, they have nerve pain and nerve symptoms. I personally, in my practice, I remember only one case in maybe 10,000 with nerve injury or something like this. And the rate in radio frequency is a little high, 2.5%, or I don't remember how much for the pain. The pain 03 for the DVT. The DVT rate is high. I don't know why. For this center, I think this center is not a big center because when you see 2,900 cases for 10 years, that means 3,000 per year. For 10 years, that means 300 per year. For one center is too little. I personally last year I performed 300 and something for one surgeon. So multiple surgeons in one center with only 3,000 in 10 years, that means it is not a big amount of patients. And this may include the low number of patients for the recent techniques. But what really triggered me is the rate of complication. I have never seen in my whole life a DVT post-varicose vein in a case of cold state, primary varicose vein, not secondary varicose vein. Maybe I'm lucky, I don't know, but I'm speaking about thousands. So if we speak about repeated DVT in all techniques and not small amount, I'm wondering why. I don't know if there is any explanation in your opinion when you dig inside the paper, but really what bothered me in this paper is this high rate of nerve injury and deep venous thrombosis. But thank you very much for your presentation, and it was a very nice topic to select.
Thank you, Dr. Khalid.
Thank you, sir. Professor Omar Farouk, if you have any comment, please.
بسم الله الرحمن الرحيم. Thank you very much. Very nice presentation and very nice appraisal. I agree with most point that he has said, and regarding the new techniques and new technology, which is found in the last 3 years, and this is called the front-loaded paper, which mean from the start it was just a single arm, which was only varicose vein surgery, and become front-loaded with radiofrequency new technology, which is bad for the design. I actually use artificial intelligence to confirm my feeling about the paper. Do you like me, Professor Mustafa Shal, to share a screen?
Yes, please, sir. Yes, sir, please.
Okay. So, I think you need to stop sharing screen, so I will be able to share
Stop
screen.
sharing,
Yeah.
Dr. Talat, please.
Okay. Okay. So, I will show you here something which is little bit different. There is a program which is called Notebook LM, where I upload the paper and it actually can convert the paper into podcast, which is something that we didn't used to. So, for example, this paper I have converted to podcast. Someone will say, what is the advantage of this? If you are riding your car, you don't have time to read the paper. Here
Welcome
it
back,
is.
everybody. Ready for another deep dive?
Absolutely. Let's do it.
All right.
محمد حضرتك
So today we're
بتبهرني والله.
tackling
أنا مبسوط
varicose vein
جدا.
treatment.
بارك
Sorry?
الله فيك.
What do you say, Professor Khalid?
بقول حضرتك بتبهرني وانا مبسوط جدا والله بنتعلم منك كل يوم.
That's okay. So listen to this.
Ooh, good topic.
Right. You guys sent in some really interesting research that compares 4
The
different
voice
methods.
is of
It's a
low
lot
volume,
to
sir.
unpack.
It is. It is.
So we're going to try to, help everyone figure out what.
Maybe the voice will not be good. So you can convert the paper into conversation so you listen to it, which is fine. So I now will ask the artificial intelligence, what is the disadvantage of this paper? Now, the difference, if you put this question to Gemini, Gemini will go all over the internet. But Notebook LM will only go to one source, which is just paper. It will not go anywhere else. It will read the paper, analyze the paper. It is called reasoning program or reasoning artificial intelligence. And here is the answer. And I will see how much he agreed with Dr. Muhammad. Number one, the study has several limitations. Number one, it's a retrograde design. Dr. Muhammad had said that. Number two, it is non-randomized study. Dr. Muhammad have said that. It is single center experience. That's right. Limited follow-up. And he mentioned here the limited follow-up. Variability of patient characteristic. And sometimes incomplete data. And surgical preference. The study noticed that treatment selection could have been influenced by the reality of the country and the preference of the surgeon. So this also affects the outcome. So it totally agree with the opinion of Dr. Muhammad. Incompetence of SEEP, all this is really good. So I will give this a good reply. So this reply is artificial intelligence. Take your question and get you the reply. And I'm interested in the point that Professor Khalid said regarding quality of life. What score did the paper used? So now, as if I'm speaking to the paper, and as if artificial intelligence will get the answer from the paper. So here he will say that the study used Aberdeen varicose vein questionnaire, which, as Professor Adil Amhawi said, this is not the best one that we use because it has a lot of defects. And here are some key points in the Aberdeen varicose vein questionnaire. The Aberdeen score administered pre-operatively to establish a baseline. I'm not sure if this has been done or not. It was administered as follow-up evaluation, 2 weeks, 3 months, 6 months. And he will go on through criticizing the AVVQ assessment. Okay, let's get him a difficult question. So what do you think is the best quality of life score for this study? This is a difficult question. This one really needs someone who is a researcher to know from this study, from this number, from this value, what is the best. Well, the study acknowledged the nature of AVVQ. The study notes the treatment selection could have been influenced. Therefore, while the AVVQ score show improvement across all group, its interpretation should be done in context with the study limitation. So he did not give me a better score. You know, there is someone called LA 125, which is very commonly used in UK, but he didn't mention that. But the beauty, he gave you the reference that he took this answer from. So here AI can give me a nice chat. This is the source, which is the paper, and even it can convert it into a conversation. So if you don't have time to read it, you just
For one
listen
of the
to
less invasive techniques like RFA or CAC or OCA.
All right. So we've got patient preference.
Yes.
We've
Sir,
got vein
you actually
characteristics.
are
What else?
surprising us with everything new, and everything is
it. Okay, so I
compatible
will stop
with
sharing
our
here.
busy time now.
Yeah. And so my opinion that artificial intelligence at the moment can be as good as a good senior registrar in his reply. And I congratulate Dr. Muhammad for very good information and all the very good point from Professor Kamhawi, Professor Khalid. I will, after this Zoom, I will go and ask why there was a big number of DVT, because he will go to the paper, get the number of DVT, get the author, and do a research over the internet to tell me why there was a high incidence of nerve injury and DVT. And this one cannot be done easily. So it saved me a lot of time.
Actually, sir, it's mentioned in the paper that it's common with cyanoacrylate closure.
Yes.
They all, most of the cases of DVT was with cyanoacrylate closure.
Yeah,
It's
that's
true.
true.
6.4%, but in the stripping was 2.3%,
Yeah.
and radiofrequency 2.3%. I don't have the studies. I have been working with radiofrequency more than 1,000 cases now,
Yeah.
and I have 0%.
Yeah.
I did not see a single case.
Yeah.
So I think there is a problem of the technique. That's why I'm stressing on this point.
Yeah.
And when you find the nerve injury, for example, in great saphenous vein stripping, I don't know how much, maybe 2.3%. This is technical error. That means these surgeons are not brilliant surgeons, I mean. So you cannot compare result of a very skilled surgeon with starting surgeon. So when you start a study, you have surgeons with excellent results, and then you standardize the results, and then you make your study. Dr. Adel عايز يضيف حاجة. اتفضل.
Yes. I have one case of deep vein thrombosis after varicose vein surgery, saphenofemoral disconnection, and I was in Charing Cross, and there is voting to use prophylactic anticoagulant with varicose vein surgery or not. This was 10 years ago, and most of them refused to use prophylactic anticoagulant. But I was and I am using standard prophylactic anticoagulant for economic causes, because 14 days with prophylactic anticoagulant will not harm the patient medically or socially or cost. I prefer to be
It's better.
in side.
It's better.
Now, I remember this patient and the swollen limb after varicose vein surgery It is only one case. But after that, when I used the prophylactic anticoagulant, I had no patient. But now you can see in the conferences or the eminent venous surgeon, they are using routinely now prophylactic anticoagulants. You can believe this. This one point. Other point about the number of the cases. As you know, Dr. Khalid, in United States, 30% of vascular surgeons were not exposed to venous surgery. This is very important. For the large centers or big centers, they perform varicose vein surgery at the weekend, Friday normally. They collect the patient. They have 5 to 7 cases every week. So every month we have 20. So over the year we have 200. So over this 10 years, so we have this 2,000 patients. As you know, in Charing Cross, we met this vascular surgeon from Turkey, and he had said I had performed cyanoacrylate in 2,000 patients over 1 year. Who can believe this? I am working 200 days per year. So I am performing every day 10 cases cyanoacrylate. So this is near to the logic to perform 2,000 cases over 10 years in a large center performing varicose vein. So I agree with this number.
May I add something regarding the prophylaxis, just
Yes.
for the brainstorming and discussion? When I started my vascular residency in France, it was 1987. And by that time, we used to have 3 weeks post-operative prophylaxis by low molecular weight heparin. And I continued there maybe for 10, 15 years. And then when I came back to Egypt and started to do some private, I got a question from the insurance, why it's so expensive, your operations, because you are prescribing for 3 weeks low molecular weight heparin. Then I started to discuss with this subject with my colleagues بدون ذكر أسامي يعني in Ain Shams University, and they all said nobody is using this. So I started for insurance purpose to stop the low molecular weight heparin prophylaxis, while the other patients who can pay, I continued. And honestly, since 1987 till now, I did not see a single case of DVT. And for that reason, I stopped completely, maybe since 15 years or 20 years now, using prophylaxis.
Yeah.
The most important thing that I want to underline just for the discussion for the younger colleagues, the nerve injury or the great saphenous vein, it comes when you dissect the segment at the premalleolar status, because the vein is completely stick to the nerve. So when you make the dissection here, you have to see the nerve, dissect the nerve away, so that when you put your plastic olive and you pull, you do not pull the nerve. So it's completely technical. Regarding the DVT, for the radio frequency, I was a proctor for the Echo machine, it's a Chinese microwave. It's very important to respect two things. First, the size of the veins that you are cauterizing by radio frequency. You should not exceed 10. There is a lot of publicity and a lot of studies saying that we are doing 20 millimeter, 30 millimeter. These are nonsense, because the producer, the productor himself do not recommend to use more than 10 millimeter, because the heat will not be enough to coagulate more than 10 millimeter. Second thing, we have to respect the distance between the saphenofemoral junction and the tip of the caster. We have to respect at least 2 centimeters. There is a lot of surgeons said, no, we go to the junction, no problem, and we did not face any problem. I think these two issues are very important, and honestly, alhamdulillah, and I touch wood, I did not face any of these complications, and I think the technique is very, very important to practice.
May I give a comment? Small comment?
Of course.
Yes,
Yes.
sir. Sure, sir.
As I worked in Germany, we had a complaint from the patient in the court against the vascular surgeon because of hyparesthesia or dysesthesia in the leg after varicose vein surgery. And it was a dilemma. You cannot prove this injury because it is a subjective from the patient. I cannot measure this dysesthesia or paresthesia or. And in a workshop in France, I had met Jean-Francois Houle, and he had an atlas about the relation of the veins and nerves. And the embryology, the stimulus of formation of the vein is the nerve. So you can see the relation between the nerve and vein. This is a very famous atlas from Gourmand. So if you inject sclerotherapy or make microphlebotomy or thermal, it is a neurovascular bundle. And
Only at the level of the
yes.
leg, not
Yes.
from the knee upwards.
Yes.
That's why for radio frequency, you have to go at the
Yes.
level of the knee.
Yes,
Never at
I
the level
must
of the
be
melon.
away and avoid thin people and tumescent and so on and so on. But I mention this because of the relation of the vein to superficial nerves. It is there nearby, and the insult may be tingling. Some patients after varicose vein surgery says, I have no sensation on the dorsum of the foot, in the leg, and so on, but everything will improve over time. But dysesthesia and paresthesia is annoying for the patient, and varicose vein surgery is most common performed vascular surgery procedure for the patient to go to the court against vascular surgery.
I did
Yes.
like the comment of Professor Khalid Abdelal very well, and I think the owner of this paper should go and review his strategy regarding this high volume DVT, and they must review also their prophylactic policy. I think Professor Walid Khireba have put in the Q&A some question. If you like to take them, Professor Mustafa Sheikh.
Yes, Dr. Walid Qaiba about his first question. Would the introduction not include in the methods of treatment the microwave or hybrid one? This is for the saphenous vein. And in the second comment, he tell us that he exclude the history of superficial thrombophlebitis and the recanalization that occur. In his third question, no clear definition of recurrent lower limb varicose vein, and the next that in the recommendation, we must have international scoring system that may be in the near future will introduce one for re-evaluation to add or remove some parameters. And the next, he want to highlight that there is no clear or standard international definition of recurrent lower limb varicose vein, which raise up many question mark about the research in this title. And lastly, about the thromboprophylaxis that must be related to the risk of thrombosis, as well as the risk of bleeding scoring system, regardless the name of the operation. Thank you, Professor Kreba.
I will just take some of this question, very nice question from Professor Walid Khireba, which is an eminent researcher. Well, actually, this paper is one of the rare papers that it define recurrence. And I did like their definition because they define recurrence as reopening of vein that has been treated by closure. So if you got the closure to great saphenous vein until the knee, and this segment's been treated and it has reopened, again, this is a definition of recurrence. So this was actually nicely mentioned in the paper. Secondly, obviously we need a better parameter for the quality control of the post-operative for patient of varicose vein. This is absolutely right. And I agree with him. And we don't know which is better, really, the quality of life questionnaire, Aberdeen in one of the old one, but not used anymore, Aberdeen. They use multiple scoring system by psychologists and psychiatrists, and they are not really very conclusive in the last evidence. But the nice thing about this paper, it mentioned different complication in different technique. So more DVT with cyanoacrylate, more recurrence with surgery, and also quite a high number DVT with surgery. And the incidence regarding superficial thrombophlebitis, this is interesting. I used to do endovenous ablation long ago, and I used to send him to sonographer. He come to me superficial thrombophlebitis. So I told him, can you show me what is superficial thrombophlebitis? Well, he go to great saphenous vein, which has been obliterated, and he sees that it is occluded. He said, well, this is a superficial thrombophlebitis. I told him, no, this is not superficial thrombophlebitis because there is no great saphenous vein with the flow at this stage. It's already been, the intima has been burned, and this is the way it looks like. And after I done him this, I start to do my own follow-up. So I never tell the patient to go do duplex somewhere else. I will do your first duplex, which is 2 to 3 days post-operative. And this is very important because when I discuss a lot of duplex scanner, they don't know the definition of post-operative superficial thrombophlebitis after endovenous ablation. But I think the nice point that Professor Khalid Abdelal have mentioned is they are not exquisitely fantastic member. They are not doing a high number. Definitely the person in charge, there is a learning curve which is inside the 10 years. So they start in using this technique, starting to have problems, start to change. So the learning technique is inside. All this have caused a lot of, let us say, a lot of vague conclusion. Because if you want to say that all these techniques are equal, no, they are not equal. Cost is not equal, complication is not equal, technique is not equal, learning curve is not equal. Even if you say collectively the life questionnaire was equal, but they are not an equal procedure. So there is a lot of criticism in this paper, I agree. And thank very much, Professor Khalid Abdelal, for your critique to this patient, and Professor Walid Khireba. Yes, Professor Adil.
Dr. Walid Khireba, yes, Dr. Adil, please.
Yes. Dr. Walid is right. There is now a scoring to give prophylactic anticoagulant after the procedure. It will be selective, not for all the patient. It depends on score, obesity, and. This one point. Other points, if a patient had superficial thrombophlebitis in the contralateral side and had a varicose vein on the other side, we had better experience after varicose vein. We had deep vein thrombosis in the operated limb. And our suggestion, we searched in the literature, but we couldn't find the ulcer. We could say superficial thrombophlebitis is a step in hierarchy of venous thromboembolism. Superficial thrombophlebitis is the most common, followed by deep vein thrombosis, followed by pulmonary embolism. So we say if a patient had previous superficial thrombophlebitis in the contralateral side and symptomatic varicose vein inside, we recommend prophylactic anticoagulant in these patients to avoid the risk of pulmonary embolism and medical-legal problems. We had these cases, actually. Thank you.
Yes, Professor Khalid, please.
Yeah, it's very important, because you open a discussion by just starting for a paper, and we found a very interesting brainstorming. Just for the case that you mentioned, Dr. Adel, I personally, in case of thrombophlebitis or any inflammation in the body, I do not operate, especially varicose veins, because varicose veins, all you know, that is never urgent, and it lasts for 7 years, and there is some symptomatic treatment by elastic stocking, like elevation, and so on, till the effect of the inflammation subside, and then we do in the best condition.
You are right.
Kind of irritation.
You are right, Dr. Khalid. Dr. Khalid point. You are right, but the patient had history of superficial thrombophlebitis since about 6 months, and there is now recommendation to perform varicose vein in the affected limb with superficial thrombophlebitis after 3 months, but I couldn't find evidence-based medicine for this or guidelines.
Absolutely. But however, I want to raise 2 other issues. First of all, radiofrequency has one very common complication. It's like a kind of pigmentation, a degree of pigmentation. Despite the best luminescence that you can do, Sometimes, especially in thin patients, the nerve or the vein, is very, very superficial. And whatever the best tumescence you do, still you may get a little burn of the skin. And this is the only thing I noticed. It is not permanent. It disappears after a while with special creams. But I think this is one complication that we have to consider. The second that I want to discuss with all of you, what would you do in case of secondary varicose vein after DVT? Which one to treat and which patient you don't want to treat? This is a good debate.
Yes, this is very important, Dr. Khalid. You need the answer or
No, I
just
wanted
read
to discuss with the younger generation in order to make them a little bit participate in their thinking, because surgery is all special techniques and special wise ideas. That's all. Then you practice it. That's it. So, what do you think?
Yes, sir. If you allow me, in my opinion about the patient with secondary varicose vein due to deep system affection, and presented to us with the secondary varicose vein, I will treat the problem of the deep system first. If he complain of stenosis or occlusion of the deep system, I will treat him firstly for the affection of the deep system. Then I will put him for medical management and elastic stocking for at least 3 months. In these 3 months, I do 2 duplex scans for the patency of the deep system that I have treated. Then I will manage the superficial system affection firstly by a very light manner in the form of foam sclerotherapy for the superficial tributaries that affect them by bleeding or sub-ulcer veins, something like that, and I will continue for the compression therapy until he completely improved. I will not go for surgery.
Dr. Mustafa? Because if you can translate it into a real patient, then you have a patient with femoropopliteal. I will not speak about iliac. Okay, femoropopliteal, extensive DVT, and this guy has been treated for 2 years, on and off, and he has now partial recanalization, let's say 70% of the deep system, and he has huge dilated varicose veins. Now he comes with obese legs and swelling and heaviness and pain. And I will not say ulcer in order to make the discussion easier. So what will you do? Because there is partial recanalization, 70%, which is not little, and he has a secondary varicose and he has symptomatic. So what do you suggest? How will you deal with this patient?
First of all, a professional duplex study for assessment of this patient, especially for the superficial system and its tributaries. For the complicating tributaries for this patient, in my opinion, I will treat it either by foam sclerotherapy or many flipectomy, not more than this.
Insufficiency of the great saphenous vein.
It's insufficiency for the great saphenous. Okay, I know, but I still have a deep system affection. So I will manage the tributaries just by foam or by many flipectomy to manage the condition that he comes to me with it. And I will put him for on medical management and compression for at least 3 more months for confirmation that his condition is improved and for much more recanalization of the deep system that he complained.
But so let's agree that this patient will continue for the symptomatic management for life, right? So all patients will have this. But if you treat the tributaries only, and you leave the great saphenous vein with a huge reflux, so you will create another tributaries later on, so you are not treating it. And besides, if you treat the tributaries alone, would it be sufficient for the relief of his symptoms? Or would you suggest something else?
And I will put him for compression therapy.
Absolutely. Does anyone want to add something? The juniors.
Yes.
The juniors, what do you think? Dr. Radi and Dr. Talat. What do you think? Don't worry. You say whatever you see. This is our role to discuss. So don't worry. Tell what you think.
I think after failure, if we failed to treat the patient using conservative measures, we might use cyanoacrylate to ablate the great saphenous vein.
Especially cyanoacrylate, what for?
It was mentioned in the paper that they used it mostly for C6 patients who are having ulcers.
That means they are better than other technique for these patients?
Yeah,
I don't know.
it was mentioned that it was better for treatment of ulcer patients with incompetent perforators.
طب انت رايك ايه في الكلام ده؟
يعني I haven't tried it before.
اوكي. دكتور طلعت تحب تقول حاجه؟ قول رايك عشان
Yes.
نسمع الدكتور عادل
I
هينزل لنا في الزبد بعد كده.
I do think, Dr. Khalid, that due to the fiction of the deep system, I have to keep my intervention minimal. As Dr. Mustafa said, I will keep my compression till the improvement of the deep system to give me the chance to intervene. That's my concept.
حلو طبعا كونسرفاتيف برضه وتفكر وتاخد وقتك. It's not bad idea too.
I want only to know that Dr. Walid gave us a nice comment that he in his suggestion that the recurrent lower limb varicose vein is anatomical and radiological development of varicose vein after clinical, technical, and radiological successful ablation. This is his definition about the recurrent lower limb varicose vein. And finally, he said that no rule for recurrence with skillful hands, who stuck to the golden rule of individualization of the patient according to the cost effectiveness of the procedure, and after proper decision making with meticulous achievement of all steps of the operation, which lead to clinical, technical, as well as radiological success. Thank you, Professor Kreva, for your comment.
Very good comments.
Dr. Adel.
Thank you. First of all, I want to say my MD thesis was about post-phlebitic ulcer, and I did all the techniques, even brachial vein valve transplant into popliteal vein. So from the superficial to the deep. And my conclusion is, if I have secondary varicose vein and it is symptomatic in the form of cosmetic, this is one point, or bleeding, another point, or superficial thrombophlebitis or complicated varicose vein, this is another point. If we go to the duplex to see there is recanalization of the deep veins, is this enough? No, this is not enough. It is clinical. How can you prove clinical that the superficial vein is enough? You know the modified birth test and so on. But clinically, it is very simple. You have congested secondary varicose vein. If you elevate the limb of the patient and there is collapse of superficial veins, so the deep veins are enough. If there is still congested, so the deep veins are not enough. This is very important point. I see that the ablation by endovenous, whatever the method for secondary varicose vein, is better than surgery. For the bleeding, injection is the best. Superficial thrombophlebitis to be treated by systemic anticoagulant in intermediate dose and intermediate period. And if we have ulcer, we are allowed to treat according to Dr. Mustafa Shal said, if there is proximal stenosis or obstruction, we must recanalize. If there is occlusion, we can do bypass and so on. But only in recalcitrant. Recalcitrant means very resistant ulcer. And the publication now, or the journal editors, will not accept any paper talking about central venous stenting by indication of edema and so on, only in recalcitrant venous ulcer.
I will just
Dr.
add a
Mohammed.
small comment. Yes,
Yes.
in the ESVS guideline 2022, there was
Yes.
a lot of new guidelines, especially in this era, which is the one I did like a lot. That post DVT recanalization is not a contraindication to ablation of great saphenous vein. This is one of the guidelines of ESVS. So my strategy, as simple as that, you have two sources causing patient symptom. Deep system, superficial system. Deep system, the best treatment we have is compression. There is no other way that can treat even the axillary vein autotransplantation. So deep system, I put the patient on compression and review the patient after a couple of weeks after compression. Because compression treat the deep system and compress most of the superficial system, not all of it. And I tell the patient, are you comfortable with the stocking? If yes, this is the end of the story. Keep on stocking, unfortunately, lifelong. Secondly, if he's still symptomatic after I've done compression, I don't worry at all about performing ablation to great saphenous vein with the deep system already recanalized. And this is according to ESVS guideline. It is actually one of the new added guidelines, which was not before in the ESVS 1918. So this is a new guideline. And in my clinical practice, I have performed it quite a lot. Post-phlebitic limb with obvious secondary varicose vein, as long as he's generally fit and there is no thrombophilia, no other special risk factor, I don't worry. I treat the great saphenous vein by endovenous ablation. The second guideline, which is interesting, it doesn't matter which way you treat the superficial reflux, as long as you treat superficial reflux. So you can use foam, and you can use MOCA, you can use phlebograph, you can use endovenous laser, endoradiofrequency. All of them are equal in treating superficial reflux as opposed to phlebitic. It did not mention special preference to special technique. So you do what you are already good at, familiar with, and don't worry about the post-phlebitic. They usually have plenty of veins in the deep system. I haven't seen complication with this technique, which is phlegmasia cerulosa dolens. I haven't seen it in any of the patients that I have done superficial. So this is, in short, my philosophy or my strategy with my based guidelines.
Completely agree with you, Dr. Muhammad.
Okay.
Endovenous treatment in both phlebitic or thrombotic is better than surgery.
Yeah.
For many reasons.
Yes.
Also, varicose vein in patients with lymphedema, lipedema, and post-thrombotic syndrome.
I totally agree.
If you can, because some cases you cannot do endovenous ablation, especially if the artery, the vein is tortuous.
Yeah.
You cannot. If you have segment of occlusion.
Yeah.
So in fact, this question is just it's very interesting because this is not an MD. This is the European College of Vascular Surgery debate. The idea is there is no best answer, but the idea is how to see, what's your opinion, how to see the case. We all agree that it must be case oriented. That means we have to decide each case by case. Second thing, what I want to add, that you have never to neglect the cause of the DVT. If the patient has coagulopathy, definitely it will affect your decision. And third thing, the degree of recanalization is very important. I remember very much, there were a discussion, I don't remember the name of the surgeon, maybe he was Cockett himself, or someone very famous in the venous disease. And he said that do not accept venous recanalization below 70%. For him, if you reach 70% of recanalization of the deep system, that means that your deep system is functioning normally. Even it is 70%, but it is good. Unless, if it is less than 70%, then you have to continue treatment because you have the period of 2 years of treatment after acute DVT. During this time, you are capable to treat the thrombus, which is a little floppy. But after 2 years, it becomes completely a band of fibrous and it will never respond to treatment. So the quality of the treatment depends if you treat early and if you treat during the first 2 years. If after 2 years you achieved 50%, no matter whatever you do after that, you cannot achieve better. So if you have recanalization more than 70%, then you can ask the question to relieve the superficial system, whatever the technique is according to the patient. But if the recanalization is less than 70%, I personally do not recommend to touch superficial system because it will be the system of relay of insufficient DVT and deep system. So it is a debate and it has to be tailored for each patient, but it's very nice to discuss.
Very nice, Dr. Khaled. there is another point about compensation of the body after deep vein thrombosis. Normal palmar bypass, suprapubic venous bypass.
Natural bypass.
Yes, I had performed a lot of ablation of this vein because it is very annoying for the patient in this suprapubic area and in the sexual life. And I hadn't
Infertility
find,
also.
yes,
Because
yes,
of fertility.
yes. And to ablate this vein is very important, and I think it is one type of secondary varicose vein, but it is not in the leg. Better to be ablated, but not endovenous surgery is the better.
I don't want to interrupt this fruitful, precious talking, scientific talking actually, but now we have about 65 minutes of this precious scientific talking. I'd like to express my great thanks and great happiness about this criticism from my young colleagues, Dr. Talat and Dr. Radi, and the precious criticism of my professors, Dr. Aidel, Dr. Khalid, and Dr. Omar al-Farouk, and for sure Dr. Walid Khriba, that I will try to connect with him after this journal club to ask him for his valuable participation in the next one, inshallah. I'd like to thank you all, my professors and my dearest young colleagues, and if I have anything to be said, that I'm so happy for this time, hour of valuable talking, really. Thank you, all of you, sir. Thank you, Dr. Khaled. Thank you, Dr. Omar. And thank you, Dr. Radi and Dr. Talat. Many thanks for you. And inshallah, we will be with us in the third journal club of the EVC in February 2025, inshallah.